Welcome to Journal Club, updates in chronic inflammatory demyelinating polyneuropathy, diagnosis and emerging therapies. In this episode, Getting a Grip on CIDP, Dr. Diana Castro and Dr. Jeffrey Allen discuss some of the latest presentations and clinical data coming out of the 2024 American Academy of Neurology meeting. They will review updated results from the ADHERE trial of weekly subcutaneous efgartigimod, a recently approved treatment for adults with CIDP, as well as new data on emerging therapies. Journal Club is developed by Projects and Knowledge powered by Kaplan and is part of a continuing medical education series. This independent CME-CE activity is supported by educational grants from argenx US Incorporated and Sanofi. Information about the faculty and disclosures can be found at journalclubpodcast.com/CIDP2. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Castro is a board-certified neurologist and neuromuscular physician. She is the founder and director of the Neurology and Neuromuscular Care Center and the Neurology Rare Disease Center in Denton, Texas. Dr. Allen is a professor in the Department of Neurology, University of Minnesota in Minneapolis. I am your host, Candace Hoffman. Dr. Castro will begin our discussion.
Hello, my name is Diana Castro. I'm a neuromuscular physician, and I'm here today with Dr. Jeff Allen. We will be talking about some of the presentations at the American Academy of Neurology, which are exciting presentations on CIDP. I'm going to start first just before I let Dr. Jeff Allen talk a little bit more in depth about these studies. Let's just review really quick. Proven efficient treatments are corticosteroids, IVIG, and plasmapheresis. We have other therapies that we have modified, let's say IVIG, now we have also sub-Q IG, but it's important to discuss some of the new therapies that are coming. One of them is the hyaluronidase with sub-Q IG for the treatment of CIDP. I think this is a very important type of therapy when we have patients that have difficult access for the IV treatments. And I think also it's important when you're going to try to fit the treatment between your daily life. Wouldn't you agree, Dr. Allen?
Yeah, this is an interesting development in traditional subcutaneous IG, where essentially you can combine subcutaneous IG or immunoglobulin with hyaluronidase, which allows you to get large volumes of immunoglobulin into the subcutaneous space at one time. So essentially, you can get IVIG-like doses, but put it into the subcutaneous space. Do it maybe every 3 or 4 weeks. So it's a potentially nice option for some patients.
Exactly. And this study was a phase 3 trial of patients with CIDP, and it was randomized, double-blind study. So what they found, they look at patients that were, again, they divided patients that were going to get the medication, the sub-Q, or going to get placebo, and they look at the relapse rate at 6 months using some of the tools we have discussed before, the INCAT, the IROTS, and safety and adverse events, obviously. And what they found is that it's actually effective for prevention of relapses with a difference between the placebo and the treated arm of 21.8%. So the sub-Q is definitely a good alternative for patients, like I said, that had such a hard time sometimes getting IV or fitting it within their daily life. So let's just talk a little bit more about the other new medications that are also coming into as options, Jeff.
Yeah, well, I guess we should mention that we're going to focus on kind of some of the newer therapies that were discussed at the recent AAN in Denver. So maybe shall we start with the FcRn antagonist and talk a little bit about those?
Yeah, let's talk about it a little bit. Do you mind describing some of the the mechanism of action really quick for us?
For sure, yeah. So the FcRn antagonist, it's kind of a slick mechanism. This FcRn receptor we think is really, really important for basically recycling antibodies and IgG immunoglobulin levels. It's kind of a gatekeeper receptor where if you're bound to that receptor, whatever is bound gets kicked back into the circulation and is spared. And if you're not bound, you get taken up by lysosomal cells and basically get destroyed. You get catabolized. And so if you've got a targeted therapy that blocks this receptor, basically tricks the body to chew up and destroy of all these IgG antibodies that are potentially pathogenic. It takes away IgG levels as well. But it seems to be a good way to get rid of pathogenic IgG antibodies by blocking that receptor.
I know, and I know there have been different trials. Some of them completed a negative trial, and we have a positive trial, and some others that are coming. Would you mind talking about some of them?
Sure. So maybe the ADHERE trial is the one to start with. This is one that was presented at the recent AAN. And this is studying a drug called efgartigimod, which is a subcutaneous weekly injection of an FcRn antagonist. It was a fairly complicated and thoughtful study, and it basically had four main components that I think are important to focus on. The first was a screening component. Screening phase. And in the screening phase, patients, of course, had to be seen by an investigator and showed that they actually met all the criteria for the trial. But also, really importantly, those patients had to have all their data reviewed by a confirmation panel. And that confirmation panel had to look at their data and say, yeah, we think more likely than not that you have CIDP and you meet the criteria for CIDP. So it increased confidence. Of course, we know that diagnostically CIDP can be tough. So this was an important phase of the trial. Patients that were confirmed diagnosis then went into a run-in phase. For the run-in phase, if you were on treatment, standard of care, IVIG or steroids, you had to stop that treatment and show deterioration. If you showed deterioration, then you could go to the first stage A of the trial. And not everybody was on treatment. You could be treatment naive or not on treatment and still be eligible for this trial. Of course, if you were not on treatment, you didn't have to go through the run-in, you just went straight to stage A. So stage A was an open label phase of the trial. So in this open label phase, everybody got open label efgartigimod. You know, whether you're coming from the run-in phase or if you were treatment naive, you all got open label drug. And in stage A, what was need to be seen was that you had to have some sort of evidence of clinical improvement. And that could be demonstrated on a number of different outcomes, either an INCAT disability, an IRODS disability, or a grip strength measurement. Once you showed that you were improving in stage A, then you went over to stage B. And stage B was the randomized placebo-controlled phase of the trial, where then you were randomized to either a weekly efgartigimod or to placebo, followed for 48 weeks. And then what we were looking at was a relapse rate during that 48-week period.
So they were first in one part where they were all getting the medication, and they were moved to one where they were getting a placebo or treatment.
Exactly.
So what did we find?
So in stage A, so this is though you're just looking at improvement in stage A, whether you're on treatment or coming from treatment or treatment naive. And what was shown that if you just look at the people that were improved in stage A, 67% of patients improved in that stage A. Now, I should say also that the outcome measure in stage B was an event-driven outcome measure, which meant that once the 88th person relapsed within the clinical trial, the trial was shut down. So because of that event-driven design, there were people that were still in the screening and the run-in and the stage A process when the trial was closed. And so what that meant was that there were some patients that didn't get the full opportunity to improve in stage A because this trial was closed. If those patients were removed from the trial, then the stage A responder rate went up to over 70%. But I think we can say a minimum of about 67% improved with open label stage efgartigimod. In stage B, then you're looking at relapse rates and prevention of relapse. And what was shown in stage B was that in the placebo group, 54% of patients relapsed compared to 26% treated with efgartigimod, for a difference of roughly 26%, and a lower risk of relapse in the treatment versus placebo group of 61%. So clearly meeting its efficacy outcome for prevention of relapse in stage B.
And these are weekly injections, right?
That's right. So those of us that are treat a lot of myasthenia gravis patients, we know that this is different in myasthenia gravis, where those patients were treated in those trials and subsequently in clinical practice, typically with weekly cycles times 4, and then you take a break for a month or two. This study was designed differently, just weekly.
Got it. Yeah, exactly. That's what I want to bring that point to, because it definitely I use it for myasthenia gravis, but now it's going to look a little bit different. I think it's also important to talk about negative trials. And one of the ones we have was with a medication called rosaneluximab, which we call ROSI for short because it's a really long name. And what they look here was for the same type of mechanism that you were explaining before. It was a phase 2 trial on patients with CIDP. It was multi-center and randomized. The subject and the investigator were blinded, and there was a placebo-controlled group. The patient, like you said, the key inclusion was to be able to confirm that they did have CIDP. They were able to be, so they were before on a stable IVIG or subcutaneous IG for at least 4 months. And what they did is, again, randomize patients to the ROSI or placebo, looking at safety, looking at change in IRODS at week 13, change in the INCAT or change in grip strength, very similar to what you saw before. And then what they found is that they enrolled 34 patients, but there was no difference in week 13 in IRODS. So both groups were about 70% stable, which is showing that unfortunately, again, there was not a difference, a significant difference. So that's why this was a negative trial. But tell us also about, there are 2 more trials that are going on with a similar mechanism. Is that correct?
It's hard to know what to make of the rosaneluximab trial. That trial was now presented at AAN this year, but it was recently published. You can look that up, published in May of 2024. So all the details are in the publication, but it was a smaller trial. They didn't use a confirmation committee. Maybe there were some differences in the population of patients who were enrolled, but nonetheless, it didn't seem to show benefit as far as prevention of relapse in that small trial. So I think knowing that there's 2 other ongoing FcR antagonist trials is really, really important. So one of those trials is with a drug called nipocalimab. The other is with a drug called batoclimab. Both of those 2 trials are ongoing. They're both recruiting patients right now. They both have study designs that are very similar to the ADHERE trial. So a little bit more rigorous than the rosaneluximab trials. So we'll see what they show. I think their recruitment is far underway. We'll be interested in seeing if those show results that are similar to what was seen in ADHERE or more rosaneluximab.
And then let's think about what other mechanism of action, because at the beginning you were mentioned something. So complement, I think that it's one that it's coming also very similar to myasthenia gravis. Tell us a little bit about that one.
Yeah, it's the really PRUVART study. So this is a really interesting study which takes trial design in a little bit different direction than what we saw with the FcR antagonist trials. And what this is a complement inhibitor. It inhibits complement very early in the classical complement pathway at C1. The drug is designed as a single IV infusion, and then it's followed by weekly subcutaneous injections. So subcutaneous injection is pretty easy for patients to do. Now, this trial is of interest because it looks at the treatment landscape or the patients with CIDP in kind of different groups. And it studies them all differently or independently. It's looking at patients that are on standard of care treatments and how they might behave with this complement inhibitor. It's looking at patients with so-called treatment refractory disease and how they might respond, and then also patients that are treatment naive. We've got some data now that was presented at AAN in 2 of those groups, the standard of care treatment group and the treatment refractory group.
So what did they find in those, for at least the 2 groups that they were presented?
Yeah, so the treatment refractory or the treatment standard of care group, so the way this looked like in the clinical trials, you got people that are coming in on standard of care, usually either IVIG or corticosteroids. You're all on that, you're stable on those drugs, and then you're allowed to continue those for a period of time, but first you have to get the open label rilipruvar. So you get the study drug, overlap it with your standard of care, IVIG for about 6 weeks, but then you have to stop your standard of care, and then you're given a little bit of longer grace period for corticosteroids because those can take some time to taper, but then you have to stop that as well. And then patients are monitored over 24 weeks, and what you're looking for is a relapse rate or patients that have a change in their INCAT score for the better or worse during that 24-week period. For the treatment refractory group, it's a little more straightforward because those patients aren't on any treatment when they come in. So they're just started on their rilipruvar at the start of the trial, and then they're monitored also for 24 weeks, looking for changes in INCAT scores. So if you take those two groups separately, the standard of care treatment group and the treatment refractory group, the standard of care group showed that during that 24-week period, 88% of those patients were stable. And of interest, a fraction of those, about 40%, were even improved compared to their initial standard of care baseline, which is a pretty notable finding. If you look at the treatment refractory group, about 50% of those patients, improved from their baseline, even though they had not demonstrated that prior to that period in their standard of care when they were previously treated. So some interesting results, early results. It's a phase 2 trial, but something to keep note of.
And just to clarify, so the group that was in standard of care, the overlapping time was around 6 weeks. That's what you said, at least for IVIG. Corticosteroids a little bit longer, but then we're completely off.
That's right. The IVIG group, 6 weeks. The steroid group, I think they were given up to 12 weeks to taper off, but they had to eventually get off.
Got it. And I think that is worth mentioning also rituximab, because I think rituximab is something that we use commonly as off-label. I have personally used in patients with nodopathies, with neurophascine, for example. So there are some studies around that have shown some good response. So there was at least a randomized controlled trial in Japanese centers where they look at rituximab 375 milligrams weekly times 4 versus placebo, and they treated some of these patients with neurophascine. So patients with neurophascine, and they were positive and negative, and they look at the proportion of patients that were improving. These studies we're still waiting results, but I think it's important that it's coming out because, again, we use it commonly as off-label. There is another study, an Italian study, that is looking also at open-label rituximab 1 gram, 2 weeks apart. So it's a completely different way to give the medication. And then they will continue the patient on IVIG for 6 months, then stop. And they will be also looking at, again, the proportion of patients that worsen at 6 and 12 months. We still waiting a result for that. And just to mention again, rituximab can be used in different doses, different ways to give. For example, for myasthenia, we use a different dose, and then for CIDP. What is the way that you usually will treat these patients? I personally do 1 treatment a week times 4, and then I wait and retreat a month later 1 more time, and then 6 months later. What do you use usually?
Yeah, my approach is typically 1,000 milligrams twice, 2 weeks apart, and then I'll repeat at 6 months. Sometimes I'll repeat at 3 months, and then 6 months, and then beyond 6 months, I usually wait to redose, depending on whether or not I'm convinced that it was helpful or effective or not.
Exactly. So you see we'll see what those studies come up with, and maybe we're trying different doses. We're trying your doses and my dose. So I think that's what we needed to talk today about. We're learning about the importance of IgG autoantibodies and complement in the pathogenesis of CIDP, because we know it's an important target to approach. Hopefully we will have different options to treat these patients. We know that we have some studies that are complete, some studies, at least one study that was negative, but we still have things coming that are going to teach us, that are going to hopefully, again, give us more options to treat these patients better. Thank you so much, Jeff, for being here today.
Of course. Thanks for having me.
Remember, to receive your credit and evaluate this program, please visit journalclubpodcast.com/CIDP2. Thank you for joining us today.